Sound everyone. So I'll be quickly going through an overview of neurogenic thoracic outlet syndrome. So thoracic outlet syndrome is a condition resulting from the compression of neurovascular structures that traverse the thoracic outlet. There are basically three broad categories based on symptoms of the patient. So the presentation could be neurogenic, resulting from brachial plexus compression. It could be venous from subclavian vein compression, and arterial compression at the subclavian territory results in arterial toss. Most patients are middle-aged people. Fewer than 5% are teenagers, whereas 10% are older than 50 years. So the age bracket is usually 20 to 50 years. Majority of them being females. It is uncommon, but the fact is that its true incidence is largely unknown because many people with upper extremity pain, paresthesias, and symptoms have escaped diagnosis by healthcare providers who may have failed to recognize their diagnosis, considering the fact that people usually do not think about thoracic outlet syndrome with people presented with upper extremity pain. Of the subtypes in which thoracic outlet can present, neurogenic is the most common presentation. More than 95% of the cases of TOS present with neurogenic symptoms. Venous is usually in 2 to 3% of the cases, and arterial presentation is quite rare. The syndromes result from a combination of developmental and anatomic anomalies in the thoracic outlet, as well as physical activities and life events that predispose individuals to become symptomatic. Usually, a common initiating event is history of trauma to the neck, which causes symptoms in patients who may be predisposed to its development based on anatomic developmental anomalies of the thoracic outlet. So this is broadly speaking the etiology, predisposing factors, pathology, and symptoms. I've taken this picture from Rutherford. So basically, broadly speaking, the symptoms usually involve, if I specifically talk about neurogenic toss, is extremity pain, paresthesias, weakness, occipital headaches. Few individuals can present with Raynaud phenomenon type symptoms as well. Physical examination shows positive response to provocative maneuvers like modified loose chest. Similarly, diagnostic imaging involves MRI followed by nerve condition studies and EMGs to really identify neurogenic thoughts. There are three anatomic spaces that pertain to the thoracic outlet. The first one is the scalene triangle, then the costoclavicular space, and lastly the pec minor muscle. The costoclavicular space is traversed by the subclavian vein and is the most common site of vein compression. Artery and the brachial plexus, which basically causes neurogenic toss, traverse the thoracic outlet between the anterior and middle scalene muscles, also referred to as the scalene triangle. This basically is the most common site of brachial plexus compression. When present, cervical ribs and anomalous first ribs also compress the plexus in this location. So this is a pictorial representation. So we can see there are three broad spaces: costoclavicular space, the scalene triangle, and minor space where compression can occur. Scalene triangle causes compression of the plexus and pec minor as well. Usually, vein is compressed in the region of costoclavicular space. This is another picture that is showing that venous triangle is basically is the area where vein is compressed, the costoclavicular area, and this is the area where artery and neurological symptoms occur between the scalenus anterior and medius muscle. This is an X-ray of right complete cervical rib. So basically, this is a pictorial or a graphical representation of anomalous first rib or cervical rib compression on the plexus. So this is how the ribs can show us if there is cervical rib or anomalous first rib on X-rays. In addition to brachial plexus, there are a few other important nerves that are passing through the same territory. The phrenic and long thoracic nerves are seen during supraclavicular dissections. Very close to the area, but rarely seen, are the dorsal scapular nerve and cervical sympathetic chain. If I talk about the plexus, so we all know it arises from the nerve root C5 to T1. In the scalene triangle area, the five nerve roots, they become the three trunks. The anterior and posterior divisions and cords of the plexus are usually formed proximal to the pec minor space. So it is the branches of the plexus that lie under the PM muscle or the pec minor muscle, along with the axillary artery and vein. If we talk about phrenic nerve, this usually arises from C4, but they take supply from C3 and C5 as well. It is single in about 87% of the cases, but they can be duplicity or triple nerves can be present in more than 10% of the individuals. It descends most of the time from the lateral to the medial side of the anterior scalene muscle. In few individuals, that is about 15 to 16%, the phrenic nerve remains on the lateral side of the muscle. So if it remains lateral, the chances of compression are comparatively less. Then we can have long thoracic nerve. It arises from C5, C6, and 7. The C5 and C6 branches run through the muscle belly of the middle scalene muscle, where they usually join together. C7 arises from the posterior aspect of the nerve root and often descends below the middle scalene before joining the other two branches. So the C7 part of the nerve is more prone to compression. The dorsal scapular nerve, it is the first branch of C5. It goes through the sympathetic portion of the middle scalene muscle and then descends lateral to the muscle. However, it may course very close to the area of dissection supraclavicular approaches to thoracic outlet decompression. Last is cervical sympathetic chain. Though it is not usually in the operative field of supraclavicular procedures, the cervical sympathetic chain lies over the transverse processes of the cervical vertebrae and is therefore very close to the origin of the anterior and middle scalene muscles. As a result, because of the diathermy which is used to exercise the scalene muscles at their transverse process origins, the current may reach and damage the cervical sympathetic chain, and this is the probable explanation for the occasional cases of Horner syndrome observed after supraclavicular splenectomy. There can be a few variations and anomalies of the scalene muscles. A significant number of anatomic variations have been observed in both normal population and in patients with neurogenic TOS. These variations might be regarded as anatomic and developmental variations predisposing to thoracic outlet syndrome, but they may not be considered as primarily the cause. Splitting of the anterior scalene around C5 and C6. This splitting was noted in about 45% of cadavers and in only 21% of NTOS population. Similarly, scalene minimus muscle can also have a role. It arises from the transverse processes of the lower cervical vertebrae and runs in front of C8 and T1 and behind the subclavian artery and inserts on the first rib or the substance fascia. Its incidence is 25 to 55%. So it is not always present, but in half of the population it can be found, and it can be potentially one of the reasons or variation in scalene muscle anatomy. There can be interdigitating muscle fibers. The scalene triangle width can be variable. It can be very narrow or it could be very wide, with the distance between the two scalene muscles, anterior and medius, at the insertion on the first rib ranging from 0.3 to 2 cm. The nerve root emerged lower in a wide triangle compared with the pathway in a narrow triangle. Observations during surgery have revealed that most neurogenic TOS patients have the narrower type of angle, which is understandable because the space is less and there are more chances of nerve root compression. As we can see here, picture A is showing the usual anatomy where we can see the angle is quite broad and the structures are comfortably passing through the triangle. However, with narrow angles, there are more chances of compression of both the artery and the nerve. Skeletal abnormalities. As many as 29% of patients with TOS have been reported to have skeletal anomalies, including cervical ribs, cervical anomalies, isolated first rib abnormalities, the majority of which are congenital. Anomalous or rudimentary first ribs are often overlooked on routine chest radiographs. In a study that I'm quoting, it is an old study, but it shows about 5,000 chest radiographs which were reviewed, and it was found that the incidence of anomalous first ribs and cervical ribs in these subjects was 0.76 and 0.74% respectively, quite close to each other. Anomalous ribs occurred equally in women and men. In contrast, the female to male ratio of cervical rib was found to be 7:3. That is, cervical rib was more common in females. Both of these, the anomalous and cervical, are narrower and are positioned more separate than a normal first rib, hence increasing the chance of structural compression. About 30% of cervical ribs are complete ribs fused to the first rib by a true joint or a fibrous attachment. The other 70% are incomplete cervical ribs with no direct attachment to the first rib. However, most of these incomplete ribs have a tight facial band extending from the tip of the cervical rib to the first rib. The cervical rib and attached band lie within the middle scalene muscle, thereby narrowing the space within the scalene triangle through which the nerve roots of the plexus course. Thus, an incomplete cervical rib with associated band can behave like a complete rib and can produce significant symptoms. Cervical and anomalous first ribs can compress the artery and cause stenosis with or without post-stenotic aneurysm formation simultaneously as well. More commonly, these anomalous ribs compress the lower trunk of the brachial plexus and cause neuropathy. However, most of these patients, they remain asymptomatic throughout life. But having these features are a potential risk factors of having neurogenic TOS. So usually the symptoms are neurogenic. In a recent review of NTOS operations involving abnormal ribs, 15% were performed in the setting of anomalous first ribs, while 85% patients are those which had cervical ribs. Spontaneous onset of symptoms occurred in 50% of the patients with complete cervical ribs versus only 20% with incomplete ribs. So with complete rib, cervical rib, there was more pronounced symptoms. Neck trauma preceded the onset of symptoms in the other 80% with incomplete ribs and in the 50% with complete ribs. So even without the history of neck trauma, complete cervical ribs, they themselves remain a risk factor to produce symptoms of neurogenic TOS. All patients with cervical ribs are predisposed to the development of some form of TOS, mostly neurogenic one. Cervical ribs or anomalous first ribs are almost always present in patients with arterial TOS, but they may not be present in every case of neurogenic TOS. However, the chances of having neurogenic TOS is more as compared to having arterial symptoms more, as I mentioned in the beginning of the presentation, that the most common presentation is neurogenic TOS. Lastly, contribution of the pec minor muscle. The pec minor can also cause compression of the structures of the thoracic outlet, leading to similar symptoms. Pec minor syndrome results when this muscle causes compressive symptoms in the subcoracoid or the pec minor space. It is actually outside the thoracic outlet area, but compression of the upper extremity neurovascular bundle can occur in this space between the muscle and the rib of the chest wall. Although this may be termed as axillary compression syndrome, it is appropriate to consider this as an extension of the thoracic outlet area, as it comes immediately behind, immediately after the scalene muscles, and because compression here is common and the axillary and the thoracic outer neurovascular bundles contain the same element, so the symptoms are pretty much the same. It usually results from excessive trauma or exercise of the shoulder girdle by hyperabduction. It becomes tight, hypertrophied, and compress important neurovascular structures. It is frequently responsible for recurrent neurogenic TOS after thoracic outlet decompression and can be responsible for up to 75% cases of recurrence. It is this space that should be evaluated more carefully, particularly in patients with recurrent or persistent symptoms after initial operation for neurogenic TOS. Thank you. With this, I complete my overview, and now Dr. Shoaib will present the relevant article.
Thank you, Umar. That is a nice overview of the anatomy and the different presentation of thoracic outlet syndrome. So can Shoaib, you can present this article and give a critical view. Thank you.
Yes.
अस्सलाम वालेकुम वरियाम, क्या हाल है आपके? ठीक है?
Assalamualaikum. Today I'm going to present article from European Journal of Vascular and Vascular Surgery 2022. This is surgery versus continued conservative treatment for neurogenic thoracic outlet syndrome. Objective: neurogenic thoracic outlet syndrome is one of the most controversial clinical entities in the medicine. Several major cases series have shown promising results of surgery. However, solid scientific evidence is lacking. The aim of this trial was to objectify the effect of thoracic outlet decompression. Introduction. Thoracic outlet syndrome is a condition resulting from compression of the neurovascular structure traversing the thoracic outlet. Dr. Amar has given the overview about neurogenic, venous, and arterial. So this is the anatomy. So I will come to the methods of this article. It is a single center, non-blinded, randomized controlled trial. It was conducted with the parallel group design. Patients with a diagnosis of neurogenic TOS refractory to physiotherapy that was no improvement of complaints or worsening symptoms were randomized into one of two intervention arms. First is receiving either trans-axillary thoracic outlet decompression or continued conservative treatment with a dedicated physiotherapy. After 3 months, patients in the conservative treatment group were offered a trans-axillary thoracic outlet decompression. Participants' inclusion criteria: all patients with neurogenic thoracic outlet syndrome refractory to conservative management were candidates for this trial if they met the following inclusion criteria: fit for surgery, 18 years of age, Dutch speaking, selected for thoracic outlet decompression by the thoracic outlet syndrome multidisciplinary work group team. This multidisciplinary work group consists of TOS nurse specialist, 2 TOS surgeons, 2 neurologists, a radiologist, orthopedic surgeon, 3 physiotherapists. They met weekly, discuss every patient referred for a thoracic outlet syndrome, and select patients for thoracic outlet decompression. Exclusion criteria: patients who have a history of previous surgery were excluded from the study, or patient who was unfit for surgery as assessed during the preoperative anesthetic consultation, or patients having 18 years of age, less than 18 years of age. A patient who did not receive adequate neurogenic TOS specific physiotherapy for the condition were excluded from the trial. Trial procedures and endpoints: investigations at the follow-up visits were performed by neurologist independent of the operating surgeon. The primary outcomes was change in the DASH questionnaire score, disability, arm, shoulder, and symptoms. This questionnaire is a validated measure for complaints caused by ANTOS and was developed by the American Academy of Traumatology. It includes 30 questions related to symptoms of daily activities and social and physiological functions. The score ranges from asymptomatic, which score 0, to totally invalid, that is 100 score. The secondary outcomes were the change in cervical brachial symptom questionnaire, change in TOS disability scale score, or change in the quality of life. The goal of the TOS dedicated physiotherapy was the improvement of the patient's posture by strengthening the exercises and lengthening of the shoulder girdle muscle, stretching exercises of the levator scapulae, scalene, and pectoralis minor muscle, as well as strengthening the inferior muscle of the scapula are performed. The scapular assistant test is one of the main assessments of scapular function during arm elevation and abduction. The range of motion of cervical spine is also improved with passive cervical exercises. Deep manipulation of the first hip is not performed as this may aggravate the pain. Surgical technique: thoracic outlet decompression in this trial was performed through a trans-axillary approach under general anesthesia. A trans-axillary thoracic outlet decompression at the outer center consists of a complete resection of the first rib, that is from sternocostal cartilage into the costo-vertebral joint, surpassing and dividing the ligament of tubercle and anterior costo-transverse ligament. Any partial cervical rib is completely removed. The intercostal brachial nerve 2 on the way down to the thoracic outlet is routinely identified and preserved. After surgery, patients are advised to wear a sling for 3 weeks. Physical therapy is given to obtain full range of motion in weeks 4 to 6 and gradually from passive to active range of motion. No strenuous physical exercise should be initiated before 3 months post-operatively. After 3 months, the physical therapist guides the patient with progressive exercises to fully restore strength, work, and sport activities. Statistical analysis. It was hypothesized that there would be a statistically significant difference in the DASH score in patients after direct thoracic outlet decompression compared with the score for the patients having conservative treatment. Total 24 patients undergoing trans-axillary thoracic outlet decompression and 22 patients with conservative treatment during follow-up at the baseline after 3 months. after 6 months and 12 months after randomization. 3 months after randomization, the difference between the transaxial thoracic outlet decompression group and conservative treatment group for the DASH, CBSQ, and TOS disability scores were statistically significant. 12 months after randomization, no statistically significant differences were found. Results: in total, 24 patients received transaxial thoracic outlet decompression. 22 patients received conservative treatment. After 3 months, surgery was offered to all patients in the conservative therapy group. Every patient in conservative group underwent transaxial thoracic outlet decompression. Initially, there were 64 patients that were assessed for the eligibility criteria, and 14 patients were excluded initially. The 4 patients that were not meeting the inclusion criteria, and 10 patients declined to participate in the study. And then there were 50 patients randomized into 2 groups, allocated group thoracic outlet decompression 25 patients, allocated to delayed thoracic outlet compression 25 patients. And from 25 patients to 1 patient delayed thoracic outlet compression due to pregnancy during waiting time. And in the allocated group of the transaxial thoracic outlet decompression, lost to follow-up, 1 patient lost to follow-up, declined to fill the questionnaire, and they analyzed 24 patients. And in other group, they analyzed 22 patients. 2 patients declined to fill the questionnaire, lost to follow-up. Primary outcome: 3 months after randomization, and there was a statistically significant difference in DASH score comparing the transaxillary thoracic outlet decompression group with conservative group. 6 months after randomization, 6 months after surgery for transaxillary thoracic outlet decompression groups, and 3 months after surgery for conservative treatment group, no statistically significant difference was found. Secondary outcome: the cervical brachial symptom questionnaire score and TOS disabilities scale both show similar results to the DASH score. A significant difference at 3 months comparing transaxillary thoracic outlet decompression with conservative treatment. 6 months after randomization, no statistically significant difference was found between 2 groups. Surgical outcome: complications occurred in 5 patients from the transaxillary thoracic outlet decompression group. 1 patient was treated with oral antibiotic for surgical site infection. 1 patient had a transient ulnar syndrome. 1 patient transient Phrenic with solution of complaints after 6 months follow-up visit. 2 patients had persisting neuropathic pain of the intercostobrachial nerve 2, which was treated with pregabalin. In the conservative treatment group, complication occurred in 3 patients after surgery. 2 patients had interbrachial nerve 2 neuropathic pain, resolution of complaints 6 months post-operatively, no medication was provided. 1 patient had a persisting ulnar syndrome. There were no brachial plexus lesion in this group. Recurrence of symptom was seen in 1 patient in transaxial thoracic outlet decompression group and 5 patients in the conservative treatment group. Persisting neurogenic TOS was seen in 1 patient and in the transaxillary group and 2 patients in the conservative group. Discussion. In the STOPNTOS trial, the role of thoracic outlet decompression was investigated as the treatment for NTOS by comparing transaxillary thoracic outlet decompression with conservative treatment. There was a statistically significant differences in DASH, CBSQ, and TOS disability scale scores at 3 months. The conservative group was offered surgery at the time, and similar results were seen in this group after surgery. This indicates that thoracic outlet decompression surgery is beneficial in patients with neurogenic TOS who do not respond to physiotherapy, pain medication, and counseling. The general disbelief of medical practitioners that neurogenic TOS evidently exists and should consequently be treated by thoracic outer decompression surgery remains high. Therefore, a randomized control trial was performed comparing surgery with conservative group. The study designs of this randomized control trial meant that the beneficial effect of surgery alone in TOS patients could be shown by eliminating the confounding factors of the prolonged physiotherapy, optimal pain medication, and counseling of the patient. Ideally, a study protocol with a sham operation in which only an incision would be made in the axilla without performing a transaxillary thoracic outer decompression would completely abolish any doubts about the placebo effect of thoracic outlet decompression surgery. Firstly, these patients have a median duration of compliance of around 1.5 to 3 years. To postpone treatment for more 1, 2, or 5 years would be unethical. It should be kept in mind that all these patients had already had several months of physical therapy without beneficial effect on their complaints. Therefore, the smallest interval in which statistical differences could be shown between three groups was chosen. Secondly, a sham operation with an incision in the axilla might complicate future surgery. The result of this randomized control therefore provides solid evidence for the beneficial effect of thoracic outlet decompression surgery in patients with neurogenic TOS. The failure rates after 1 year of follow-up are remarkable. 8.3% in the transaxillary thoracic outlet group versus 31% in the conservative group stands out. This result is not statistically significant. A possible explanation could be the sample size. CBSQ and TOS disability scores and the failure rates at 1 year follow-up are non-statistically significant comparing groups. This result is mainly seen as due to chance rather than a real difference between the population. The study has several limitations. First, the diagnosis of neurogenic TOS remains partially subjective. The Society of Vascular Surgery reporting standards broad guidelines, but in the end, it remains up to the treating physician to make the diagnosis. Second, a sham operation would have abolished the risk of placebo-induced improvement of patients better than the current methodology of this trial. Third, the patients in the conservative group received surgery after 3 months of randomization. Although the long-term effect of surgery at 1 year follow-up on the CBSQ, and TOS disability scale scores were evidently proven in this study, surgery cannot be compared with the full year of conservative treatment. Continuation of the conservative treatment might have shown improvement beyond 3 months after randomization. Median time of complaints for transaxillary thoracic outlet decompression group was 1.5 years and 3 years for conservative treatment group. The present authors think that further continuation of conservative treatment beyond 3 months plus 1, 5, or 3 years respectively would not be meaningful. To conclude, in this trial, a beneficial effect was found for thoracic outlet decompression for patients with neurogenic TOS who do not respond to physiotherapy. Thank you.
Thank you, Shoaib. And it is very nicely presented paper, and you have nicely summarized all aspects of that. So, if my question is with you, what is the strength? If you have to say 2 or 3 strengths of this study, what are the strengths of this study?
Sir, the strength of the studies, they included the population who having symptoms of neurogenic TOS and were diagnosed from the other physicians rather than surgeons, and comparing those patients with conservative treatment group, and in the end they found that the patients who underwent surgery have good effects comparing to the patients who having conservative treatment group.
Yeah, I agree with you that firstly, they have selected very controversial topic, that is neurogenic thoracic outlet syndrome. In our setup, we find a challenge to treat these patients. One is the first challenge we find is that these patients is in the diagnosis. Diagnosis is always diagnosis of exclusion. When they reach in our clinic, they have gone through so many physicians, and they have all been kept on conservative treatment. Second challenge, which we find, we do not have the evidence whether surgical intervention or continued conservative therapy, which one is better. Thirdly, this article has actually picked a very controversial point and give us strong evidence for that. Although the study, I will say, population is less. There's about 22 patients in one arm and 24 patients in another arm, but they have used very good objective criteria. And I agree with the authors that both groups have already trial of conservative treatment for a mean period of 1.5 to 2 years. So it doesn't make a difference to continue more of conservative treatment. In our clinical practice, I am more comfortable in doing a supraclavicular approach because most of time when we have to intervene for the arterial thoracic outlet syndrome or the venous thoracic outlet syndrome. So trans-axillary approach is practiced less, although in centers and in hands which are doing this, they say that it also provides complete decompression, and it removes the bands and also incomplete rib and even complete cervical rib from the trans-axillary approach, and it also gives the good cosmetic effect. And I am very impressed by the low complication rate in surgical arm, which is there. And although there are some limitations for which they have nicely mentioned. So if there are any comments or any questions, they are welcome. Thank you.
Dr. Zia, this is Dr. Omar.
Nice
presentation. Nice presentation. I think from a comment point of view, I would say that neurogenic thoracic outlet is always the most difficult to, number one, diagnose and then to manage. I've always tried, my approach is basically of, you can say of maximum restraint, because a lot of these patients do benefit just with physiotherapy, with posture improvement, and a lot of them improve. But having said that, I have operated on a few whose symptoms have not settled, and I've seen very good results after surgery. I think the most important thing in performing surgery for neurogenic TOS is the consent process, because it is not clear how much benefit the patient is going to have. Some patients may have reasonable benefit, whereas other patients may not have. And I think this trial basically gives us, although as you said, it's the numbers are quite low, but it still gives us a little bit of something to give to the patients, so that yes, it can improve the symptoms. And these patients, they're suffering a lot, and even 40-50% improvement in their symptoms sometimes means quite a lot. As far as the approach is concerned, I have never done a trans-axillary one. I always do supraclavicular approach, and as you said, if it is a venous TOS, then a supra and infraclavicular approach combined. So yes, I think it's something important to keep in mind, and having seen the results of this trial, I would still say that be cautious in going for surgery for neurogenic TOS, as time should be given to the patient to try the conservative measures first. Thanks.
Thank you, Dr. Umar. That is great comments. And the other challenge which we find, which I see in this paper, they have developed a team of physiotherapists, team of nursing who are very interested in dealing these patients, and also neurologists. So, and there are they have made centers which are doing this specialized surgery. So that is the model which we can actually develop and work on. instead of working individually. That can give a better patient care. Dr. Freed, I see hand raised by Dr. Freed.
Thank you, Dr. Zia. Thank you, Shoaib, for your nice presentation. And I totally agree with what you and Dr. Omar Hassan has just said, that it's difficult to diagnose, but yes, constant process is really important. So I just wanted to share a couple of experiences I had during first my rotation in cardiothoracic surgery at AKU while I was fellow in vascular. So I remember we did one thoracic outlet syndrome, which was neurogenic via a transaxillary approach. And that was exactly new for me because we as vascular surgeons are not routinely doing that. And what I found was if you're sure that it's only neurogenic, which we usually diagnose before intervening, whether it's combined or isolated, then I think it was quite easy to access the first rib. And the benefit, the most important benefit of, or say the advantage of the transaxillary is getting the first rib, which is very easy because you just land onto the first rib. So that's what I found. And because the arm is abducted overhead, so the neurovascular pedicle was quite away from your surgical field. So there was hardly any chance of injuring that. The second thing is, while I was doing fellowship in UK, and you have done it as well in the same center, Dr. Zia. So you know Mr. Howard, Adam Howard. So he was quite famous and he used to get referrals regionally in the east of England for these neurogenic as well as other aspects of the TOS. And in my whole 1 year of training, I didn't see even a single vascular, the arterial TOS. They were all neurogenic and young patients. And the history was, if you take it back, they had long history, but usually they explained some trivial injury, some kind of trauma, which then incited it, and then it came to the notice. And his approach was, he said he used to give two incisions, supra and infraclavicular, but over the period of time, he has modified his approach to a single incision, which is right on the top of the clavicle, which was again something really unusual for me, but he has very good results. And then what he does is he raises flaps, just like we do in the thyroid surgery, upper and lower flap. And then through the same incision, he does both things, the supraclavicular dissection and the infraclavicular, especially for the venous toss. And his approach was to do all the things like removing first rib, neurolysis, and freeing the space in one surgery, because he believes that uh, you cannot go back in that space again like a redo surgery, which would be a disaster. Yeah, that I just wanted to share that experience. Thank you very much.
Thank you, Dr. Freed. That is nice reflection of your experiences. I also I am also remembering my time with Mr. Howard. So Mr. Howard is pro for the supraclavicular approach, and he has interest. The main important thing which I have seen is that was the planning. He was very much taking a history of the patient, making correlation, and was always planning and then giving quite good time in consent process. And one of his colleagues, senior colleague, was used to do these neurogenic thoracic outlet syndrome by a transaxillary approach, and I used to scrub in those cases, although there's little to see in those cases because one person is holding the arm, and most of the surgery they are doing by a tactile fun, but this is being done transaxillary approach, and that can be, if the people who do it, they say that it is quite easier and they know the landmarks and they can do it. But the main thing, probably the message of this article is that this is one of the neglected entity which vascular patients have. And if we have to give them maximum conservative treatment, and we have to keep one of the possibility of intervention if they are not responding to conservative treatment. This is probably the message, and probably more when the more evidence will come, we will be more strong to counsel our patient about this. But this is there, if patient is not responding to maximum conservative treatment for neurogenic thoracic outlet syndrome, it is better to actually to decompress thoracic outlet syndrome. Yes. If there is any question or comments from any other participants, yeah. If not, we can actually stop at this. Thank you for participating, and thank you, Amar, for giving a good overview, and Dr. Shoaib for summarizing the article. Thank you, Dr. Umar, and Dr. Fareed for joining us. I see Variam and also Khalil joining us, and hopefully we'll meet after 2 weeks. Assalamu alaikum.
Thank you. Thank you all.